Hello, everyone. So I'm super excited as Lee the Scientist here from Instagram and Twitter to be hosting this week's Black in Cancer. Specifically, I'm going to be moderating this discussion on addressing common cancer myths and misconceptions. Joining me today is medical oncologist Evelyn Taiwu, as well as the Onc Docs Oyunye Balagun and also Folu Balagun. So just to get started, I'm going to do a quick rundown of what we're going to be discussing today. Whole list of topics ranging from general cancer facts, going to be taking some questions from the audience, cancer risk, the importance of screenings, and of course, common myths. So first, let me get started with the most basic question. What exactly is cancer? Can we just get a good high-level description here? Let's start with the Onc Docs.
Yeah, so we're so happy to be here, first of all, and thanks for the opportunity, Black in Cancer. So when it comes to cancer, the first thing we have to understand is that our body is made up of cells. And inside these cells are genes that are made up of DNA, right? So there's an organized way that our body is supposed to have these cells divide and grow. And cancer is basically when this process goes wrong, when the cells stop dying off as they normally should, and they instead gain the ability to just keep on dividing, and they gain the ability to go to other parts of the body where they should not be. So cancer is basically when the normal cellular processes, the way our cells are now normally supposed to divide, grow, and die off, go haywire and go wrong. So.
Thank you so much. So my understanding is that you're a radiation oncologist. Can you give us a quick 10,000-foot view of what exactly that means?
So thank you for asking. I love to we're clearing up all the myths today. So I'm here on behalf of all the radiation oncologists, of which unfortunately there are not enough, minority radiation oncologists. But when we think about cancer, we tend to think about surgery and chemotherapy, and clearly those are really important. But we forget often about radiation, which is basically using, I describe it as really high-powered X-rays to treat cancer. So we use these machines to try and direct X-rays to treat cancer. And over 50% of cancer patients will need radiation at some point in the course of their treatment. So I like to think of it as another pillar, a third pillar in addition to surgery and chemotherapy of cancer care. So I don't make anyone radioactive. I won't make them the Hulk. They won't glow in the dark, but I still think that what we do is pretty cool. And I think he thinks so too, so.
So great to follow up. Bolu, can you tell me exactly how that differs from your role as a medical oncologist? And then we're going to follow up with Evelyn right after this spot.
All right, so my role is, I think, as a medical oncologist, the medical oncology part is easier than the radiation oncology part, because when I see patients, I actually spend more time explaining to them what a radiation oncologist or radiation therapy is about than I do medical oncology. Medical oncology, we simply give medications. So when people when they think of cancer, chemotherapy, drugs, anything that we call systemic. So it goes to the whole body. You take a tablet, it treats your whole body. We put something in your IV, it treats the whole body. So medical oncology covers that field in terms of cancer treatment.
Thank you. I appreciate a very high-level response. Evelyn, it's my understanding that you did part of your training or currently at Kings County Hospital. I was actually born in Kings County Hospital in Brooklyn, Flatbush. So super excited to have you on the call as well. Can you tell me just quickly, 10,000-foot view, medical oncology, your training experience, and maybe a quick day-to-day on what you do currently?
Sure. So in addition to what Dr. Folu Balogun said, medical oncologists are doctors who basically treat cancer patients with medications, whether it's chemotherapy, whether it's targeted therapy, such as monoclonal antibodies, whether it's immunotherapy, anything that we give systemically, like he said, is part of what we do as medical oncologists. In addition to that, medical oncologists generally coordinate the whole care of a cancer patient. So we have surgeons who do the surgery part, we have radiation doctors who do the radiation part, you have the medical oncologists who give the patient's medication. Not everyone needs chemotherapy. We sit there and assess the kind of cancer the patient has and make a decision as to whether chemotherapy, endocrine therapy, targeted therapy would be beneficial. And then in addition to that, we take care of patients after their cancer treatment is complete for patients who've been treated with curative intent. So we have what we call a survivorship plan, right? You finish your treatment, there's still a whole lot of follow-up that happens for many years after a cancer treatment is technically complete, which is what we do as medical oncologists. So in terms of, my training, you go to medical school after college, you go to, you do a general internal medicine residency, which is 3 years. After residency, then you do a fellowship program. Most fellowships in the country are 3-year programs where, the first couple of years may be very clinical, and then 1-year fellowship may be research focused. Some fellowship programs are actually very research focused. If you're pretty certain that you want to be more of a researcher, whether it's a translational type research or basic science research in oncology, you can find programs that are really focused on that. I'm more of a clinician, and research that I do is more clinical. So I went through a clinical program where a lot of my training, most of my training was really clinical, and I spent a year doing research. In terms of what my day's like, it really depends. If I'm on the inpatient service, we're seeing patients who've been admitted for whatever reasons they're presenting with. And in the process of trying to assess what the issue is with the patient, there's an abnormality that's found that's concerning for cancer. We get called as medical oncologists and we direct what needs to happen after that. What needs to be biopsied? Does the patient need to be managed in-house, or can we follow up outpatient? A lot of cancer care for most cancers actually happen in the outpatient setting. Then in the inpatient setting, we're seeing patients who maybe need to be admitted for the kind of chemotherapy they're getting, or they're admitted because they've had some complications from their treatment. Then we kind of manage them and sort of, put the whole patient back together. In the outpatient setting, which is majority of what I do, it's really seeing a patient for a consultation, having a conversation about they've been newly diagnosed, what that means, the stage of their cancer, what the treatment's going to require, whether it's surgery, whether it's radiation, whether it's chemotherapy, and then you're following patients throughout their treatment process. For patients who are on some sort of treatment, are they having side effects from their treatment? Do I need to make adjustments to their chemotherapy or whatever drugs that I have them on? So that's what you kind of do on a day-to-day basis. Obviously, it's a lot more complex than that, but for the purposes of this, that's I'll stop.
Well, that was fantastic. That was a fantastic response. I actually want to circle back to the onc docs and ask a very broad common question that we get all the time as researchers, and I'm sure as physicians, is that why is cancer so prevalent in the US, and what is special about it that increases that prevalency?
Yeah, so I think people ask that question often, and the short answer is that there are multiple reasons. So we'll try to go through the different reasons why. So when, many, like 100 years ago, people weren't living as long. We didn't have cures for a lot of infectious diseases. So people died at younger ages. Cancer, for the most part, tends to affect older individuals, even though it clearly happens in a lot of younger individuals. But as we've aged, we have more time for those processes that we talked about, the cells dividing as they're normally supposed to, for there to be problems that get introduced. So that's one of the big risk factors for cancer, your age, because as you age, there's more opportunity for there to be errors in the way your cells are supposed to divide. And those errors lead to the cells being able to grow without limits, leading to cancer. So age aging. An aging population is one of the reasons why there seems to be more cancer. Also, we know that there are certain risk factors, one being air pollution, for instance. So we know that that contributes to lung cancer. We also know that there are risk factors like smoking. So some of those habits, when they picked up, we saw an increase in lung cancers, and recently when those rates have gone down and we've done more screening, we've seen a decrease. So those are some of the other things that contribute to us feeling like we're seeing more cancer.
One
I'm
other
sorry, Evelyn, would you like to add to that any?
No, I mean, everything she said, exactly. We're living longer. So, you know, patients are getting diagnosed with cancer. We have, you know, environmental factors. We have risk factors. We're more obese now, which is increasing our risk for cancers. We're screening patients more, so we're catching cancers a lot earlier. I think people are also more transparent and more open about their diagnosis. So I think people are more comfortable knowing that, you know, a cancer diagnosis is not necessarily because I did something wrong. So I think we're more aware because there's also, you know, there's more awareness and people are more open. So it's a combination of things like Dr. Balogun said.
And if I can piggyback off of what Evelyn said, it never occurred to me when you just said that we're more open now about cancers and what's happening with our bodies, especially in the Black community. I think a lot of people are now rallying around the fact that when we're silent, we don't know family histories. And when you don't know family histories, how are you supposed to do the screening? So that kind of awareness, you know, hopefully is increasing and helping us to catch cancers more. We catch more numerically, more of them, but hopefully we're catching them at earlier and earlier stages, especially in the Black community.
I think it's a key.
One more thing, actually. In terms of we're catching more cancers, but people are actually living longer.
Yes.
With the diagnosis of cancer. So it's all a combination of everything that we're doing.
So I think you guys touched on some key points there, and it's good because we're going to segue right into our next topic after we got through some general cancer education. Everyone should now have a degree in general cancer knowledge now, all our viewers. But we're going to talk about some cancer risks and some questions that pertain to that. So Folu, could you actually talk to us about a question I get asked on a regular basis on my social media is that, do cell phones actually contribute to your cancer risk?
So that's a good question. I remember a while ago, maybe like a decade ago, that was a huge concern because of the explosion of cell phones, how often we use them. Everyone had a cell phone by their head and we're concerned that it was going to lead to brain cancer. Several things have happened over time. First, time has just passed. We've had cell phones with high usage for a long enough amount of time without noticing an increase in the proportional increase in brain cancers. So it's less likely that cell phone usage does not cause cancers. And there's no study so far, no detailed study that has shown that an increase in cell phone use causes cancer. There's also another argument now that whether or not there's a need for such studies, because now most people are texting or they have their headsets. So you rarely see someone that has a cell phone to their head anymore. So when we were supposed to study it, we didn't have enough time to learn. And now it may not even be a useful question anymore. But as far as we know, cell phones do not cause any increase in brain or any other cancer. Neither does 5G.
So don't go burn down your 5G tower in your neighborhood.
So that's a great point to make. I see Evelyn agreeing over there, but I'm going to follow up with Evelyn with a different question. I know obesity is definitely a huge risk when it comes to cancer, but specifically, we got a Q&A question from one of our audience members, and they want to know, what is the relative impact on diet and cancer risk? Evelyn, can you take the floor and talk to us about that?
Oh yeah, that's huge. I think the number one risk factor for cancer in the US is obesity. It's associated with breast cancer, it's associated with colon cancer, it's associated with pancreatic cancer. We know in patients who are obese, there is higher inflammation going on in the body. And we know with the higher rates of inflammation, there's a higher risk for cancers. It goes back to when we talk about diets. There's certain foods that cause this increase in spike of glucose in the body. We have very good data showing that the increase in the spike of glucose in the body increases the rates of inflammation in the body. Once again, that contributes to cancers. So I get a lot of questions from patients because they've read this online. Well, if that's the case, so does that mean, you know, sugar is gonna increase my risk of cancer? Or even patients that already have a diagnosis of cancer, they're really worried. They want to cut sugar out of their diet completely. And what I tell them is it's unlikely that that's going to change anything. All cells in the body need sugar, which is glucose really, need the glucose for function. The problem is when we're ingesting foods that are high in glucose that causes an increase and a spike in the blood sugar level, an increase in the spike of insulin levels in the body. All those contribute to inflammation. So what I generally would recommend patients do is look for higher fiber foods. There are tons of healthier forms of carbohydrates, which eventually produces glucose in the body. It's not necessarily the sugar itself, it's the refined sugars and what it's doing to your body when you ingest it. There's no steady state of glucose in the body. There's no steady state of insulin in the body. You're having the spikes on and off, causing inflammation. So diet is definitely huge. We have very good data now showing that increased, you know, ingestion of red meat increases your risk of certain cancers, particularly colon cancer. I mean, let Dr. Balogun talk a little bit about that because his focus is on GI cancers, but we have very good data showing that as well. We have data that certain foods, red meat included again, when they're cooked, that the breakdown, you know, leads to some more complex, not so great byproducts in the body that also increase the risk of cancer. So.
Fantastic explanation. Actually, my PhD was focused on chemotherapeutics and DNA damage response in GI cancer. So I think me and Folo actually are kin here in the GI cancer space. But I'm going to change degrees, essentially 180 degrees, and switch to melanoma and ask this question: do Black people need to wear sunscreen? because we're, you know, I wouldn't consider myself light skinned, but if I'm at the beach, do I need to wear sunscreen, or is this darkness just good enough to stop me from getting squamous cell carcinoma or melanoma or things of that sort? I'll let the onc docs take this question.
Yeah, so I think, you know, I'm gonna confess, I was of the mindset that, you know, I'm Black, I'm doing my thing in the sun, this melanin is gonna, I'm fine, until I went for spring break with one of my friends in college and I got sunburnt. And you can get, and that's the thing, you know, the in the sun, when we're out in the sun, we're absorbing something called ultraviolet rays into our skin. And that has the ability to damage those cells, introduce damage into those cells and make the way the cells divide go wrong. So that's the basic risk, because when that happens, you can then develop skin cancers down the line. If you keep on, you know, exposing your skin to those ultraviolet rays, you increase the risk for damage and you increase your risk for skin cancer. So my people, please, the melanin, it looks good, but just put a you know, a coat of sunscreen on it, because we definitely are at risk for skin cancers.
Can I comment on that a little bit?
Of course, elaborate.
Just last year, yeah, no, this topic is actually quite controversial right now. And there was an article in the New York Times last year, and this woman had actually written about, you know, as you know, sunscreen beneficial in Black people. And it looks like right now, I mean, absolutely what Dr. Balogun is saying is what we need to do. If you're not even concerned about cancer, we're concerned about other damage that the sun, you know, causes to our skin, hyperpigmentation, melasma. So even for cosmetic reasons, sunscreen is beneficial for darker skinned individual. I think in terms of the benefit of sunscreen, what we know for sure is people who tend to burn easily definitely have a higher risk of skin cancer if they're exposed to the sun for long periods of time. So it's more about your ability to burn, your ability to tan. Do we have data for sure showing that there's a benefit to using sunscreen in Black people? I think you'll find people arguing one way or the other. We don't have clear data for that, but all dermatologists who focus on skin of color recommend that all Black people wear sunscreen. So I agree with Dr. Balogun on that.
Yeah, very interesting. I picked up tennis recently, so I've been out, playing a lot of tennis, and I think I got a sunburn for like the first time in like a decade, and I almost forgot what that's like. But cocoa butter, baby oil, that's all good and gravy. But if you're going to be in the sun, pick up some, SPF, whatever it is. Got a question from the panelists, a very specific question, so I'll just go ahead and read it off. It says, so with the key risk factor being directly linked to obesity and microenvironments, is it safe to consider some cancers a diet-linked disease? So this is kind of an interesting question. I think that there's, broad data on this, and I'd like whoever wants to take this question, go ahead and just unmute yourself and shoot. It's like Jeopardy, the Onc docs just quick on the buzzer.
I know, it's all theirs. Go for it, Onc docs.
Oh no, I think I'm gonna defer to Folu, because you mentioned red meat and colorectal cancer earlier. So
I think a simple answer to that is yes. There are some cancers that are strongly tied to diet, and we have some examples that we hear about in terms of if you have increased amount of smoked foods, you have an increased amount of specific types of cancers like gastric cancer.
yeah.
And we know that as Dr. Taiwo clearly stated recently, that our diet can lead to obesity, which can increase the risk of several cancers, breast cancer being one of them, as she clearly delineated. But there are other instances too where, like the one with gastric cancer I just mentioned, where specific types of foods can increase your risk of specific cancers. That being said, it's not necessarily, it's all in moderation.
Yeah.
Moderation is the key. For most foods, even when we say foods can lead to specific cancers, if you eat it in moderation, that's not the problem. It's because we eat a lot of it. And you find it more in different parts of the world based on our dietary preferences.
Yeah, I mean, I'll confess, I love ice cream. He knows this. I could eat it 7 days a week, but should I eat it 7 days a week? No. So I try to tell, like you said, moderation is the key for everything.
So I just want to add something real quick. Generally speaking, when we're talking about risk, if you would totally avoid these foods, that doesn't mean you're not going to get these cancers, just so people are very clear about that. Talking about risk association, it's not a exactly linear relationship. Eat a burger, get a polyp, doesn't exactly work that way. Healthy, balanced diets, exercise, these are the things that we should be striving for within our culture. So I think we talked about risk quite a bit. Of course, I want to segue, just for the sake of time, to another thing that's very important, cancer screenings. And there's a particular example recently with Chadwick Boseman, Black Panther, GI patient, had colorectal cancer, metastatic, 40s or something, young 40s, he probably was diagnosed in late 30s. How important is screening, especially for African Americans in this context? Evelyn, I'm gonna let you take a shot at this one.
I mean, screening is very important. I think there are certain cancers that we know for sure that screening really reduces, mortality rates and morbidity. So there's certain cancers like breast cancer. We know mammograms actually save lives. Colon cancer screening with colonoscopies, we know that. Cervical cancer screening with pap smears for women. PSA in men. The PSA screening is a little controversial, or was at some point, because it's clear that most men, as they get older, will eventually develop prostate cancer. Most men will die with prostate cancer, not from prostate cancer. And it's trying to figure out who has a prostate cancer that requires a whole lot of, surgery, radiation, and whatever else that we do. So screening is absolutely important, because what we know for most cancers is if we're able to catch a cancer, detect a cancer at a very early stage, or sometimes if we're able to detect a cancer before it's invasive, in the pre-invasive stage. So whether it's ductal carcinoma in situ in breast cancer before it becomes an invasive breast cancer, whether it's picking up polyps in colon cancer, whether it's picking up dysplasia in cervical cancer from screening with pap smears, when we're able to find and detect abnormalities early and provide or do some sort of intervention, it really prevents the progression to cancer. Once you're able to catch a cancer early, the risk of it progressing, the risk of it becoming metastatic is really reduced when you're able to do something before the cancer cells develop the ability to invade the body. So screening is absolutely important. There's certain cancers where we don't have great screening tools. For us to decide that screening is absolutely beneficial to any cancer type, you have to decide how many number of people need to be screened for me to actually catch one cancer, right? If I need to screen 1 million people to catch one, then yeah, maybe screening is not so helpful, but screening is definitely beneficial in some of those cancers that I mentioned.
Yeah, just to add to that, Evelyn, to speak generally, catching the cancer earlier changes this cancer treatment dynamic. You know, there's different therapies that are in what we call, the adjuvant. Surgery is an option when you catch cancers early, you can remove that tumor from the body. When cancer's in a later stage and it spreads to local organs or even all over, you're looking at systemic treatments that mostly aren't curative in a late setting, specifically in the pancreatic setting, even in the GI setting. And we've seen positive data for cancer screenings, especially in the lung cancer setting as well, where screening more patients has, increased overall survival. So another question I'm going to talk about with cancer screening specifically is that a question we have here is that there's definitely stigmas associated with seeking out care in the Black community. So I'm very passionate, particularly about increasing the amount of African Americans that are enrolled in clinical trials. The NIH, other cancer centers, they have a catchment area, which is essentially the area that their cancer center pertains to. We need to increase this. What do you think medical oncologists and even radiation oncologists, healthcare as a whole, can do to specifically address this need to try to get communities more empowered to seek out physicians and, have a better interaction with physicians in regards to oncology? Evelyn, your mic is on, so I'll let you take it.
Oh, okay. I mean, I think what's important is there are very many reasons why you have this disconnect between the Black community and the medical community. There is a history of the Black community being used and being mistreated in the medical community. You think about the Tuskegee, you think about, sterilization of women. I mean, these things were happening up until the 70s. So there are people who are actually still alive and remember these things. So there's a lot of distrust. So I think what we need to do as oncologists is we need to sort of, at least when in terms of clinical trials, we need to normalize clinical trials. We need, obviously, part of it is having more people of color in the medical field. So I currently practice in Brooklyn, and it's interesting talking to some of my other colleagues who are not people of color and the difficulty they have in enrolling patients in clinical trials versus, me talking to my patients and saying, oh, there's this trial, I think you're gonna benefit from it, and they don't have a problem with it. So I think what's important is for patients to feel empowered when they have physicians that they feel like they trust, then having the conversation with them about the benefits of clinical trials or about follow-up is really not that complicated. When patients trust you, they show up. So we need to kind of see our patients as a whole. We need to have, ask questions about what barriers they have. We're constantly thinking about our barriers or how the physician sees the patient, how we've sort of decided what we think the patient would benefit from or not benefit from without talking to them. I think it's important for us to ask the patient, what exactly are the barriers that you're currently battling with that's making it hard for you to follow up, show up to your appointment, or just not want to follow guidelines? And you'll be very surprised when people just break it down. Their reasons actually make sense. There's so much distrust. They're hearing different things from different people. And it sounds very simple. You really just need to listen to your patients. So that's what we need to do. And that's what I'm trying to encourage some of my, colleagues that are not of color who have their preconceived notions about some patients. Oh, that is a difficult patient. And it's like, no, actually, she had to run here from work and she's trying to find someone to watch her 2 kids and she needs to leave. The reason she's upset is she's waited in the waiting room for 30 minutes. And so just talk to her. So, I mean, it's not very medical, it's not very scientific, but this is the human part of medicine. And I think when it comes to marginalized communities, you kind of need to bring it down to a human level. And as you kind of grow and we become more, and this patients become more included in the structure of what we're trying to accomplish in medicine, then you can kind of start having a lot of those scientific, sort of conversations with the patients. But it's very simple, I think. I don't know, onc docs?
Yeah, actually, just for the sake of keeping the flow going, I'm actually going to make this an organizational question for the onc docs, and I want one response from each of you. What do you think is the #1 thing or the first step cancer centers can make to help address some of the issues that Evelyn just expanded on?
So my #1 thing is, do not sit in the ivory tower of your hospital and just wait for people to come to you. Integrate yourself in the community. You should be willing to go and give talks in the local library and give talks in the church and go out and meet people. You shouldn't just be sitting there waiting for the patients to come. And then when they come, you don't accept their insurance. So I think you have to work on your relationship with the community. Trust begins when there's a relationship. So there has to be a foundation and there has to be a relationship. So I believe firmly, and I know Evelyn, we work together, feel the same way too. Our group at New York Presbyterian Brooklyn Methodist has been doing outreach. The New York Presbyterian system in general has been doing outreach into the Brooklyn community because it's important to us to not just sit in the hospital and expect people to trust us. We have to be willing to establish a partnership, a true partnership, where people from the community have a say in what are we doing? How are we delivering care to their communities? So for me, that's the one thing. Go out into the community and really establish a true partnership.
I think I'll go with, in addition to the wonderful things they've said already, to understanding and personalizing support. So each group of people have unique challenges or unique obstacles that they overcome or things that they deal with. They have different points of views and different places they're coming from. In order to facilitate, for example, bringing more Black people into clinical trials, we have to, as institutions, understand what challenges they may have and put in place things that would directly that would tackle those. One example from a talk I actually heard earlier today was they had trouble in recruiting patients because some patients did not have a reliable phone to communicate with them. So socioeconomic status, it does, for example, higher proportion of Black people are below the poverty line than non-Hispanic whites. So things like socioeconomic status, keeping in mind that there may be some of our patients, some of our population that do not have a reliable phone. How are we going to make sure that we have systems in place that will keep them within the trial? Because when you cannot get in touch with someone, they may fall out of the trial. They may not even have the opportunity to enroll in the trial in the first place. And that's how they get excluded. So we just have to be able to understand where people are coming from and create an environment to support them.
Yeah, I would agree. I would say that the infrastructure of cancer care needs to incorporate socioeconomic status, because socioeconomic status impacts every aspect of a person's life, whether it comes from their day-to-day life, including their cancer treatment. I want to just quickly touch on some of the Q&A questions, not to, avoid getting to these questions. So, interesting question, I think is a very common question amongst, young women and even older women, is that at what age should females, have mammograms yearly? What age should they start that process?
So we actually currently have guidelines, and there are 2 separate guidelines. Generally, we use the United States Preventative Task for services, and their recommendations tend to be a little bit more conservative. And what they've decided is that for breast cancer screening, that it's starting at age 40 if you want, but generally age 50 and older. However, the American Cancer Society actually, and those are the guidelines that I follow, and I'll tell you why. The American Cancer Society recommends cancer screening starting at the age of 40, which is what I generally recommend. The reason why is particularly when it comes to Black women, there's a higher incidence of triple negative breast cancer, which is the most aggressive form of breast cancer. So higher incidence in Black women. Black women who get diagnosed with triple negative breast cancer tend to be younger. And when Black women generally present with their breast cancers, they present at a higher stage, which generally is more difficult to treat. So if we're screening women at the age of 40, it allows us to actually catch things earlier, be able to treat it, prevent metastatic disease, and prevent the morbidity and mortality associated with breast cancer. So I screen my breast cancer patients starting at the age of 40. Now, if you have a family history of breast cancer, or you have some breast cancer associated gene, then the screening is actually a little bit different. We start screening with mammograms and sometimes MRIs starting at the age of 25 in patients that have a BRCA1 or BRCA2 mutation. There are also other breast cancer associated genes. So, but for everyone, let's say the standard patient should be really age 40 according to the American Cancer Society guidelines.
So you touched on a key point here. First of all, you answered the question. Thank you so much. Also, genetics. BRCA1, BRCA2 mutations. These are tumor suppressive genes that get mutated. They increase your risk for cancer. Let's talk about the role of genetics in cancer diagnosis and care. So when we're talking about genetics, how much of a role does genetics actually play to cancer risk? And I know this is going to be an answer that say it kind of depends on the cancer type. So I'm going to let the onc docs touch on this a bit. What are some key cancers that have a strong genetic element? And if you are thinking about, hey, should I get screened? What things should you be looking for from a genetic perspective?
So that's a great point regarding genetics. I'm not sure that our community tends to get tested as often as other communities. In fact, one of our colleagues published on this, that the screening, genetic screening isn't used as often by the Black community, and that's something we have to work on. But the cancers that can be affected by genetic risk, of course, breast cancer. Dr. Taiwo mentioned that if you have genes like BRCA1, BRCA2, those are some of the most common. There's certainly others that have been discovered, but those genes can increase your risk for breast cancer, pancreatic cancer, prostate cancer, so ovarian cancer also, and a number of others. So if if you suspect that you have a family history, they have different requirements that show that say that, oh, you definitely have a family history. But I'd say, like, if you're relative, if you know that someone in your family got cancer when they were younger than 40 years of age, when they were younger than 50 years of age, that should set off alarms for you. And if it's multiple individuals in your family, especially if you have more than one relative, so they talk about first degree relatives and second degree relatives, so like your mom, your dad, your brothers, your sister, that would be first degree. But if you see multiple people in your family who have cancers, that should set you off to start thinking, could there be something going on here? The other cancers we have to watch out for that kind of come together are endometrial, cancers of the uterus, and colon cancers. So people may not usually make that connection, but there is a syndrome and there are genes that control your risk of having those cancers. So if you notice that there are a lot of colon cancers and uterine cancers, even if there are just a lot of colon cancers or a lot of uterine cancers in your family, that may have a genetic risk. So
are you referring to Lynch syndrome in this context?
I'm referring to Lynch syndrome, yes. But there are others, but the vast majority of cancers we know are unfortunately due to bad luck. There was a study that came out saying that most of the majority of cancers are just due to the fact that something happened to go wrong in your in that process of the cells dividing. But again, we have to be vigilant and say, you know, what did that person die of? Don't be afraid to probe a little and
Yeah.
say, what was it exactly that, you know, she died of or my grandfather died of? And if things just don't even sound quite right, I would bring it up with a physician, because you may be the one to change how things are going for your family. You may be the one to start off the early screening for your family.
Yeah, just to add some clarity to, this context that you expanded on. When we're talking about family risk, we're really talking about what we consider germline mutations. These are mutations in genes that we inherited. Your mother, your father, grandmother, these are passed down, and those genes can increase your cancer risk. It's important to know if you, one, are at risk, but it's also important to know for your tumor type, because targeted therapies in the context of, you said ovarian and breast, in the BRCA1 or 2 context, we have therapies like PARP inhibitors that are specifically used for those cancer subtypes, right? Also in the context of genetic testing of your tumor, there's targeted therapies in the context of lung, in the context of colorectal. If the sequence of the tumor has some specific genetic mutation, there might be therapies there that could extend the life of a patient. So genetic testing is something you should be talking about, especially if you have a family risk, but it's also something you should bring up. Even if you're diagnosed with cancer, you should opt for genetic testing with your oncologist. It's an interesting thing I'm bringing this up because the NCCN guidelines recommend doing testing for pancreatic cancer patients, like NGS, and every cancer center does not do that. So I want to make it a point. Just to get to some more Q&A questions, I'm gonna let Evelyn take this next one. This is an interesting question. I've actually never, had this question before, but can anyone speak to stress and PTSD as a direct or indirect link to cancer in general, or any specific cancers? Anyone that could opine on that, please unmute yourself.
Well, I mean, that's a difficult one because I don't think we have any studies that actually showed the direct link, but I think it's very plausible. And I think we all in the world of oncology really do believe that stress and PTSD really do contribute to whether it's increased, risks of, increase in like risky behavior that then increases your risk of cancer. So in an indirect way, yeah, you think about stress and inflammation and all of that happening in the body. But I think also just thinking about stress and how people manage stress and some of the behaviors that people sort of adopt to manage the stress and how those behaviors actually lead to increased risk of cancer. So I would say yes, maybe not directly, but definitely indirectly. I think there's a connection, and until we have studies actually showing something direct, I don't know that I have a definitive answer for that.
Well, to add to that, Evelyn, things like increased smoking as a habit can obviously lead to breast cancer. Increased alcoholism, leads to cirrhosis. Cirrhosis can lead to, hepatocellular liver cancer. So obviously being in a stressed situation, having poor lifestyle habits can then contribute to these risk factors. So I don't think that there is a direct, you lost your job and you're going to get a tumor. But if you lost your job and you start doing things that may put you a little bit more at risk, you might put yourself in a higher risk factor.
I tend to think that, like, I agree with all of you that we don't have yet the studies that say definitely this leads to cancer. But I think, like Evelyn was saying, inflammation, when your body is under siege and it's your cells are irritated, I believe that there's probably a mind-body connection. So I don't have the evidence, but I do tell my patients, look, if there are some friends and some toxic relationships, call them up and tell them Dr. B said that you have to end it and that they can't talk to you anymore and that it's doctor's orders. So I believe, in the mind-body connection. We don't yet have the hard facts, but I do firmly tell my patients to protect their well-being and their mental space, especially when they're going through treatment.
Yeah, I would say that there's actually some pretty good studies correlating, a person's mindset and well-being and, you know, positive attitude and exercise while on treatment, as opposed to patients who are not doing those things, which I like. That's a great point. So let's segue into my next question, which is, I think I get this question a lot, whereas when someone is diagnosed with cancer, how come there's different outcomes? Like person A and B both get the same treatment. You know, he gets a, you know, Snickers, I get a Snickers, his cancer goes away and mine doesn't. Like, why is there such a differential outcome in regards to treatment? I'll let Evelyn take a shot at this and then allow the docs to follow up with their response, because I know this is going to be a complex question to answer.
Right. I mean, I think if we go back to what Dr. Balogun said when we first started in terms of cancer is basically abnormality in our genes. We are all unique and have our own genes. So I think when we talk about cancer, there's this generalization of what cancer is. You have a stage 2 breast cancer and you have a stage 2 breast cancer and we treat it the same. But we do know not all cancers are the same, right? When you think about the biology of a cancer, you mentioned actually doing testing on each tumor. Even though you have the same kind of cancer, you're finding different things in each tumor. And for that reason, the response to the same treatment is not always going to be the same. Everyone is an individual. And what we're hoping for in the future is that we can really individualize cancer treatment where it's like, you have cancer. Okay, we're going to sequence your type of cancer and come up with a combination and a treatment that we know works specifically for you. So not all cancers are the same. So your stage 2 breast cancer is not necessarily the same as the next person's stage 2 breast cancer. Just even on the surface level, there's triple negative breast cancer, there's hormone receptor positive breast cancer, there's HER2 positive breast cancer, and we're all still talking about breast cancer, right? And even with those types, there's still differences in the nuances of the cancer types, and that's why responses are different.
Yeah, so I would like to just jump in the middle before I let the oncodocs, you know, respond to this. But another example of this in a hierarchical standard is you think of lung cancer, big umbrella term, lung cancer. Then you split that, non-small cell lung cancer, right? Then small cell, then you non-small cell lung cancer. Then there's two, what we call histological phenotypes, or, you know, squamous and non-squamous, which is like essentially how that cancer looks under a microscope. And then if you look even further to that subtype, there's a whole bunch of different mutational landscapes and treatments for the non-squamous as opposed to the squamous, right? So, but specifically, even with patients who are within the same type, all that same type, I've got an ALK mutation, you've got an ALK mutation, you know, you give me latrectinib, how come somebody else responds to somebody else? I have an answer to this, but I'd like the oncodocs take a shot at this as well.
So one thing I like to tell people is think of the word cancer as the same thing as disease. When you say someone has a disease, you don't know what type of disease it is. Do they have a pneumonia? Do they have a heart attack? Do they have this? So different medicines you use for that. That's how diverse cancer is. And just like Dr. Taiwo pointed out with breast cancer, I've had patients with breast cancer that will tell me, oh yeah, someone had breast cancer, but this and this and this. The subtype of breast cancer is so unique, so different that they respond to different medicines. So if I treat breast cancer triple negative with the same way I was going to treat hormone positive, ER positive, they would not respond because the medicines are different. And that's just how unique it is. And a trend that's coming up in the field of oncology is actually what we call chemoagnostic treatment. So when we look closely at the molecular pattern, we dig deep and really identify the different cancers, and we treat them as such. So we don't just treat it because it's lung cancer and say this medication is for lung cancer, but this medication is specifically for cancers that have this feature to them. So we're getting more personalized in terms of our treatment in that regard. And that makes every cancer, every disease so different. Just because someone has an infection doesn't mean we're all going to respond to the same thing. Bacterial infection, viral infection, malaria, all different medicines. That's how to look at cancer.
Yeah, there's an interesting point you made there. Even with this tumor agnostic setting, there's only 2 FDA approved medicines, you know, pembrolizumab for MSI high, you know, microsatellite instability tumors across that. And I think NTRK tumors,
Yep.
That's the only other one. So this is definitely something oncologists in the community are leaning into, because this means you can give a person a therapy regardless of the location of the tumor and produce a clinical, meaningful response. But go ahead and follow up.
I think the other thing I wanted to add about why people may have different outcomes is, unfortunately, the problem with cancer is that it can change, right? That's part of why we haven't found solutions, because this disease is intelligent. So for instance, with lung cancers, you hit them with a medication that they're supposed to respond to. And initially they're responding, and then the cancer cells say, hold on, wait a minute, let me, let's switch it up. And they stop responding to the drugs that they used to respond to. So the cancer can kind of change itself so that it wants to thrive, it wants to live in your body, and it wants to keep on growing. So it can change, and that's part of the problem, why one person may respond and all the cancer goes away and never comes back, but someone who has seemingly the same disease, their cancer is able to change and take on new features that let it keep on growing and thriving, unfortunately. So that's the other part about why seemingly alike cancers can go different routes.
Yeah, definitely. There's also a probability effect. There's a mathematical, effect here. Patients are going to respond differently, just have the sheer look of probability. Patients are essentially a bell curve. Some are going to be high responders, some are going to be low responders. We don't exactly know where that patient is going to fall on that type of therapy. So it's really hard to predict that. And unfortunately for the patient who's actually experiencing this therapy, they just want answers and they want, treatment. So I understand this question. It comes from a really deep place inside of them where they're looking for answers about why isn't, my cancer responding in, this way that I read about these types of things. So there's some very interesting questions here that I'm going to continue with. Evelyn, I'll let you take this next one. Oh man, there's a lot of questions here. Very, very active. I would say, is there any utility to having whole body screening CT scans as a middle-aged man? So many cancers, it's scary. I don't think this is a real concern, I think. So Evelyn, take that question for us and elaborate on that.
I mean, that's a good question. I think it goes back to what I mentioned earlier in terms of screening. There are certain cancers that we know for sure when we screen for them, and we have screening modalities. So CAT scans are not generally what we would use to screen, say, a breast cancer or say a colon cancer. A CAT scan is unlikely to show you a very early stage, colon cancer or cervical cancer. So generally, I think for the person who's really concerned about wanting to make sure they're getting routinely checked, routinely screened, it's having that conversation with your doctor. There are certain guidelines. There are certain screenings that are recommended based on the patient's age, based on your medical history, based on your family history. Like I said, if we scanned everyone, it's unlikely that it's going to be beneficial. So we figure out what are the screening tools that are actually leading to improved survival and prolonging people's lives. Any sort of modality that we're, just sort of giving everyone that's not really changing the quality of life or changing people's outcomes really is not beneficial in terms of looking for and treating cancers. So I tell patients, because there are patients who've had family members who've been diagnosed, they're really traumatized by what they've experienced. And their concerns are definitely valid, right? So it's sitting there and saying, well, who are you? What are your medical problems? What are your concerns? Okay, we can screen for this, we can screen for that. And then follow up with your doctor, and you have concerns, you have things that you're worried about, talk to your doctor about it. But I don't recommend, whole body CAT scan, basically.
You just hit on a very, I think a subtle point, but a very strong point, is that you're talking about taking data-driven approaches to make sure patients are experiencing care that has been proven to extend the quality of life and overall survival. So I think that's super important. Speaking about data-driven approaches, though, I'm gonna let the onc docs take this next question, which is, how would you compare naturopathic cancer treatments versus chemo slash radiation cancer treatments? I don't have a strong opinion about this. I won't bias you, but go ahead and elaborate on that for us, please.
So I'm going to just take a little step back to touch on what Evelyn just talked about. Just really quickly to emphasize that screening is not without risks. If you screen, you scan someone, you see something, you may have to do a surgery to go to get it. You may need to do a biopsy to dig further. So that's where we have to balance. That's why we try to balance to make sure that the benefit outweighs the risk. So doing that whole body screen may expose more people to risk, and we actually end up killing more people than we save from those scans. So those are the things we try to balance. Now back to this naturopathic. So one thing, it's something I get very frequently, and I get it. It makes sense because we think naturopathic things tend to help us better when it's not something that's the mindset that we have. I do remind people of a few things. Number one, a lot of chemotherapy came from naturopathic things. So a lot of chemotherapy that we use today, some of the most active drugs in GI cancers, breast cancers, they came directly from the bark of a tree. You know, I can't tell you the names of those trees, but there's several of them, like plants that I don't know, but that's where they came from. What we typically do is you get the bark of a tree, in this example, like paclitaxel, and you find out that it treats cancer, and you find out what part of it actually treats cancer, and you try to photocopy it. You make more and more of it, because if we just keep getting from the tree, we'll run out of trees, and those trees take decades to grow, and then we can't treat people. So we need to be able to replicate it. So that's one thing. A lot of these medicines come from that, and even the ones that are not directly from that, we try to develop them from make a better medication. So that's one thing, that chemotherapy and medications are not that all bad. They're not all artificial. Another thing is really the ways we know what medicines work is with studies. So we essentially, the most ideal way, gold standard, take two groups of people that are pretty much the same in terms of age, gender, level of disease. You give one group a medication, you don't give the other group the medication, and you see who does better. Many of these naturopathic medications, those studies or stimulus studies have not been conducted that can tell us more comfortably, like you said, data-driven, that this medication actually works. We all know an example of someone who took something and it just worked for them. We all know an example of someone who smoked 10 packs a day up until they were 95 and they never got cancer. But that does not mean smoking does not significantly increase your risk of cancer. So we cannot use data based on just knowing one person or a few people. A more organized study will give us better answers. So in a lot of naturopathic medications, we don't have that data that can tell me whether or not it works. So that's what I tell them. Those that we have studies for, I'll tell you about them. Those that we don't, I can't say if it'll help.
So I'll in my day-to-day, I talk to a lot of physicians as a consultant, and I remember this one conversation I had, which is like, if a patient says, hey, I want to rub, peanut butter on my feet, as long as they're going to keep coming in for treatment, I'm not going to tell them not to rub the peanut butter on their feet. So it's an interesting thing. I feel like this is something that happens to medical oncologists a lot, because we're dealing with drugs, but is there as a radiation oncologist, do you feel like you have to diffuse these types of conversations where you're getting asked about natural type treatments, even in your clinical setting?
Definitely. I think, radiation has a really bad rap because all we know is like Chernobyl, all these Fukushima, that's what we tend to think like radiation is bad. And people have a hard time wrapping their minds around, okay, so now you're telling me radiation is good. So that's one of the things that I have to first deal with. And also people do want to know, can I take these supplements? Will it, while I'm taking radiation? And the thing is with radiation therapy, the way it works is it does damage the DNA, of the cancer cells, as well as nearby normal cells. But the normal cells are able to heal themselves, and usually the cancer cells cannot, so they kind of, get destroyed. So when you have certain drugs that you're taking, what they're doing is interfering with how the radiation works to damage the DNA of the cancer cells. So it's absolutely important. Like I bring it up myself as part of our discussion, that please let me know what drugs it is that you're taking so that we can discuss, is this something you should continue to take during your treatment, or is this something you should hold off on? Because I don't want to be, I don't want to have to say, oh, it's all or nothing. It's possible, that this might help. I may not have the data, but we know there are certain drugs you should not take during the radiation. So discuss it with your doctor. Most are open-minded. Maybe you can't do it during radiation, but perhaps afterward, you can continue it again, as long as it doesn't interfere with anything else. So I definitely have to, confront that issue as well.
So I'm going to follow up with we're running close to time, so I want to follow up with another question. But essentially, let's just assume that patients are going to come in, agree to the treatment that we're taking. They're still going to rub the peanut butter in their feet, but they're going to agree to the treatment. They're on therapy, hopefully to have beneficial clinical outcomes. So Evelyn, what are some of the long-term effects of chemotherapy, of treatment modalities, even if patients, we cure their cancer or we prolong life? Sometimes some of these therapies will have lasting effects and adverse events that patients should be made very well aware of before and during their treatment. Evelyn, can you just expand on the types of conversations that you have with patients, generally speaking, when you're talking about treatment adverse events?
Yeah, absolutely. I mean, most chemotherapy drugs do have side effects associated with them. And so these are conversations that I have with every patient that I've decided to put on some form of treatment, whether it's chemotherapy, whether it's targeted therapy, everything has potential side effects. For patients that are being treated for curative intent, the goal is always to make sure that whatever potential side effects that they're going to experience from the treatment is not long lasting. The whole goal is to kind of get you through your treatment so you can have a functional and normal life post treatment. It's a sort of different conversation with patients that are metastatic, but I think those are also quite conversations to be had. So we do sign consent, right? For every patient who's going to get chemotherapy, I sit there and I explain to you what the potential side effects are. Each drug has its own side effects, but I think generally when we think of chemotherapy, most of the side effects are reversible. So for our patients who are getting cytotoxic, therapy, where there's hair loss that's associated with it, or hyperpigmentation of their skin or their nails, or nausea, diarrhea, those are symptoms that we can actually treat and manage through the treatment. The alopecia that results from chemotherapy, usually that resolves and their hair grows back after treatment. We have things like cool caps that patients can actually wear while they're getting chemotherapy. It's to preserve the hair follicles so they don't have as much hair loss. So there's that. In terms of some long-lasting side effects, we see that a lot with some drugs like the taxanes, or some drugs like there's some platinum agents that we give. Dr. Balagoon knows what they do in colon cancer with oxaliplatin. So there's certain drugs that cause really bad, what we call neuropathy, which is damage to the peripheral nerves, where patients have sometimes just numbness, tingling, sometimes they have pain associated with it. And in many patients, it may not be completely reversible, it may be something they have to live with. So in those patients, it's very imperative to follow as they're getting treated. We have different ways of grading their symptoms. And when, and sometimes you have to dose reduce. You have to reduce the dose of the medication to, reduce the risk of long-lasting effects. Sometimes you actually stop the treatment prematurely for those reasons. Sometimes you have to switch to a different treatment. There's certain chemotherapy drugs that can cause some heart issues. So those are all the things that we're monitoring. And the goal is always to make sure we don't get to a point where there's like long-lasting side effects from the treatment. So you're constantly weighing out the risks and benefits of the treatment, and the patient's very involved in the process as well. I hope that answered your question.
No, it's a fantastic response to this question. So I'm getting in the live Q&A, somebody who seems to have a special place in their heart for pancreatic cancer, just like I do. So I want to ask our, resident GI expert here. We touched on screening into pancreatic cancer, and this is generally speaking. Can you elaborate on screening for pancreatic cancer and what the options are, where you think they're going? What are the kind of key things that we can do to help, assist pancreatic cancer patients?
So one of the pancreatic cancer, as we know, is one of those cancers that has, unfortunately, a poor prognosis if it's advanced. one of the things that a lot of work is going into is how to detect it early. The earlier we can detect these cancers, the better chance we have of improving your survival. With pancreatic cancer, we don't quite have anything that would help us with, we don't have any ideal screening options at this time. In certain people, like we talked about with the genetic mutations, the germline genetic mutations, people that have certain genes, maybe in their family or in themselves, they have a much higher risk of getting pancreatic cancer. And in those people, we do know that if we screen them, there's a benefit to screening because we're much likely to catch pancreatic cancer early where we can treat it, where it's treatable, and we're less likely to cause harm from overscreening. But for the general population, we just don't have any ways or any means. There are a lot of studies that are going on now where we're testing the blood. We're trying to find things that will close into when we can start screening you or when we can scan you to check, rather than just scanning everyone from pick a random age, from the age of 30 and start scanning everyone. We're going to cause more harm. So unfortunately, for the general population, we don't have a way of screening for pancreatic cancer at this point in time. But if you do have a family history of someone that had, maybe people in the family that had pancreatic cancer or even some of the breast cancers, we can find genes that were mutated that are associated with an increased risk of pancreatic cancer. And in those people, they're actually suitable for screening. So like Evelyn has said, like Onya has said, like you've said also, keeping a close eye on your family history in terms of what people are having would actually be recommended in pancreatic cancer.
Yeah, to speak to screening too as well, patients, there's something in, oncology, as you know, and us, patients are going to learn about called performance status. And if you have a better performance status, usually you can get better treatments that are more aggressive treatments are indicated for patients that have a better performance status. Usually those treatments can extend life or have a higher overall survival associated with them. So it's important to get screened. It's important to pay attention to these things. So in these last 3 minutes, though, I want to make sure I give each of you an opportunity to plug your Instagram, Twitters, websites, channels, YouTube's, Car Magazine, whatever you got. Let people know how they can follow you, gain more information, and get in contact with you. Docs, let's start with you guys.
So you can find us on Twitter at theuncdocs.com. Oh, not .com, sorry, at theuncdocs. And we also have a website, theuncdocs.com. And our podcast, is coming out. So hopefully in about a week, we want to share stories that hopefully educate and inspire exactly what we're doing tonight. Anyone who's living with cancer, anyone who is caring for people with cancer, and also us providers, just to share that information. So.
Very good. Very excited to hear your first podcast. So I'm a dinosaur. I don't have Instagram. I don't have Twitter. I have absolutely nothing. If you want to find me, I'm on Weill Cornell Medicine's website, and you have access to everything that I'm doing and what research projects I'm working on. And that's where I'm at for now. But I don't know, I'm feeling the pressure now.
I'm going to set up your Twitter, Evelyn.
Thanks. I would say leave the scientist. You can find me on Instagram. I'm giving you the green light to slide up in my DMs, specifically about science and oncology. That's okay. Reach out to me. I'll track these guys down. Definitely send them their questions because I'm not an oncologist. I learned a lot with this conversation, just as much as I think everyone else that's paying attention. So we got 2 minutes left. If anyone wants to leave just a lasting comment or impression about something that African Americans specifically should take away from this podcast, from this webinar, each of you have 1 minute to respond.
Well, I think what you guys are doing is fantastic. This is so needed in the community. I think the more we talk, the more awareness there is out there, I think the better for the community. I think for me, the one thing that I just want to encourage patients in our community is talk to your doctors. If you're not comfortable with your doctor, if you don't trust your doctor, you have the power to go seek someone that you trust. I can't say it enough. I'll have patients come to me and cry because they have a doctor that they don't like, they feel like doesn't listen to them, but somehow they feel like they have to stick with the doctor. You are in charge of you. If you have questions, ask your doctors. If you don't trust your doctor, find a doctor that you trust. But go see your doctors, get screened, and let's get healthy, people. Let's get healthy.
And you took the words out of my mouth, Evelyn. One of my colleagues said, you know, if you go to a physician and they say don't get a second opinion, just flip the table, housewife style, and walk out. Because I feel exactly the same way. The other thing I would say is, if there are any trainees out there, we need you. You know, I cannot say how often enough how excited people are to see Evelyn, myself, you know, Dr. Agostini, my husband. Let's come through in the pipeline if you want to slide in our DMs and ask us for information on how to get through the process, because the pipeline isn't leaky. We get discouraged if you get a B. I had a colleague who got a B and they said, oh, you're not good enough for med school anymore. What's that about? So find us, reach out to us, join the pipeline. And to all the people living with cancer, we're here, we're fighting for you, and yeah, we're ready to help in any way possible.
Absolutely outstanding. Really want to thank the organizers of Black in Cancer for setting this up. What an incredible job they did finding you and hosting this event. This is such an informative way, and hopefully conversations like this bring people closer to medicine.
I was gonna say, just really quickly, knowledge is power. This applies to both people who you feel something, you're like, this feels a little weird. Don't just ignore it, don't just wish it away. Investigate it. Go to see your doctor, do whatever it is you need to do. Knowledge is power. The more you know and the sooner you know, the better we can handle things. And this also applies to the training that Onyi talked about. Seek us out, seek people out to provide you with the knowledge for a career you want to go through in medicine and oncology, and we'll always be willing to help and provide that knowledge. Knowledge is power, always.